Welcome everyone to your education session today on wound, ostomy, and continence care. My name is Misty Stevens and I'm a nurse specialized in wound, ostomy, and continence, and I will be providing your education session today. The Bladder Cancer Supportive Care Program was implemented in February of 2025 and is funded primarily by philanthropic donations. We are also grateful for the support provided by the Prostate Cancer Supportive Care Program and Bladder Cancer Canada. The Bladder Cancer Supportive Care Program is a new initiative consisting of 8 learning modules, each addressing a different aspect of bladder cancer care. In addition to today's presentation, the following modules are currently available: Introduction to Bladder Cancer and Primary Treatment Options, Counseling Services, Managing the Impact of Bladder Cancer Treatments on Sexual Function and Intimacy. And over the next few months, we will launch additional modules, including exercise for bladder cancer patients, nutrition advice for bladder cancer patients, pelvic floor physiotherapy for patients with a neobladder and bowel management needs, and metastatic disease management. Most modules will have both a group education session as well as a clinic for individualized recommendations and advice. Attendance at each of these education sessions are mandatory prior to booking for individual clinic appointments. We have set it up this way so that all the general information can be converted in the education session so that when you attend your one-on-one appointment, you can optimize your clinic appointment with specialized care. Partners are always invited to all sessions and all modules are offered both in person and virtually. This education session is presented from the nurse specialized in wound, ostomy, and continence, known as an NSWOC nurse. And this is a pre and post teaching perspective from an NSWOC, and we'll be building on the surgical physician provided information sessions prior in Module 1 that hopefully most of you have already attended. So this is how our overview will go. First, we're going to review on the 3 surgical options. Then we'll go through a patient's journey from before surgery, after surgery recovery period in the hospital, and then before discharge and leaving the hospital. We will also go over the ostomy care or continent diversion care and supplies. And then lastly, we will go through the resources and the supports that are available to you. So let's begin with your journey through your care pathway, beginning with surgery preparation. That means that this journey starts today. First, we're going to talk about eating well. It's important to consume a balanced diet to nourish the body. You may or may not need a special diet, and your physician will address this with you. It is important to consume enough protein as well as micronutrients prior to your surgery. When we do the surgery, you do lose some of the protein that you are consuming currently. And that's why you need to make sure that you're optimizing your protein intake. Most of the time, we have to take in about 3 handfuls of protein each day. Before surgery, we like you to consume about 6 handfuls of protein each day. That protein does not have to be just meat. Remember, there's other alternatives that can be legumes or avocados or nuts. All of these types of nutrition are types of protein that you can start eating today. Next, you want to stay hydrated. Drink plenty of fluids to maintain your hydration. On average, it is recommended for adults to consume about 2 liters of water a day. And it's important to make sure that you do keep up to that prior to surgery. When we do surgery, we have lots of insensible losses, which means that we're going to lose fluid. And so to optimize that fluid prior to surgery, you have to make sure that you stay hydrated. Next, regular exercises. Most people will exercise regularly throughout the day and they don't even realize it. Taking your walks throughout the day is that regular exercise. If you want to optimize your exercise, you can do things that will do resistance training. You can use weights, or you can use machines, or you can even just use cans at home, cans of soup, and lifting those up and down will optimize those regular exercises for you. Physiotherapy. If you have a physiotherapist that's available to you and you are going to do one of the surgeries that needs a pelvic floor specialist to teach you how to do those exercises, then it's important to start looking for that physiotherapist now. We want you to start those pelvic floor exercises today. We need to strengthen those muscles in order for it to be successful post-surgery for you to maintain continence. And last, let's seek support. Gather your support people, which includes your friends and family, and make sure that they're available for you. And if they can attend these education sessions, that would be a great resource for you as well. So we're going to start with moving on into the patient experience. First, you're going to do your pre-operative consults. The first one you're going to have is usually your surgeon. If you have not already done so, that will probably be done very soon. Next, you're going to meet with the pre-admission nurse. That's going to come usually closer to your surgical date, sometimes a week before your surgical date. They're going to go over all of the things you need to know pre-admission, so before your surgery, and that includes your diet, when to stop eating, when to stop drinking, and when to arrive at the hospital, and when your surgery actually will be taking place. They'll also go over what to expect in the hospital. If you need a special diet, this is where you tell that pre-admission nurse so that they are aware of it prior to you actually being admitted into the hospital. Next, you're going to meet with an anesthesiologist. They go over the particulars of your pain management as well as your other diseases or comorbidities that you are pre-existing with. That means that if you have something like diabetes, the anesthesiologist is going to optimize your medical care so that you have a successful outcome. They will also be talking about your pain management post-surgery so that they can make sure that you are up and moving as soon as possible. Lastly, you will meet with an NSWOC nurse, and that will either be in phone call or in person. If you are flying in to have your surgery because you're coming from different parts of the province, then that will probably be a phone call with an NSWOC nurse. If you are arriving in for your surgery, then it will be in person, and the NSWOC nurse will come down to either prior to you having the surgery or you'll come in for a separate appointment. The week of the surgery, if this is not already done, you will get a stoma marking, and that is again done by an NSWOC nurse. Why we do that is that we can optimize the placement of the stoma on your body and make sure that it doesn't fall in any of your curves or your creases. Last is your hospital recovery. You will learn new skills. We will discuss this in detail later on in the slides. The hospital stay is generally 6 to 7 days, depending on your recovery. Sometimes people do need to stay a little bit longer based on other health conditions, and that's okay. But it usually doesn't take more than 6 to 7 days for you to be discharged from the hospital. So these are the types of urinary diversions that we're going to talk about today. First is the ileoconduit. It is also called a urostomy, and it has a permanent abdominal stoma. Next, we have a neobladder, and this is an internal diversion, so you don't see anything on the outside of your abdomen. And lastly is an Indiana pouch, and it is called a continent cutaneous diversion, and it is a catheterizable pouch. So you do not need an external pouch on your abdomen, but you will have an abdominal stoma. So we're first going to talk about an ileoconduit. It is a permanent diversion surgery with a permanent stoma. The stoma will be located on the right side of your abdomen. The stoma is created from your small intestine and usually is about 10 to 15 centimeters of your small intestine. The ostomy appliance, also known as a pouch or a bag, is a device worn outside of the body to collect the urine. It goes over top of the stoma. Urine flows into the ostomy appliance naturally. The ostomy appliance is waterproof, so you do not need to worry about having showers or going swimming because you can absolutely do both of those. You do need to change the appliance when it's leaking and also about twice a week. This is an example of an ostomy appliance. It is cut to fit to go over your stoma on your abdomen. There is a piece on the back that's called a flange, and that is what adheres to your abdomen. It has safe glue that sticks to your skin. After about 6 months, in the lower right-hand corner of your screen, you'll see this is what your abdomen will look like. You will have an abdominal scar right down the middle of your abdomen, and you will have a pouch that's covering up your abdominal stoma. And again, this pouch needs to be worn 24 hours a day, 7 days a week, and it will be required for the remainder of your life. So an ileoconduit after surgery will look quite different, and this is fresh post-op. So don't expect it to look like it just did in the previous slide. Your ostomy appliance will be attached to your right lower abdomen. There may be some temporary stents that go into the abdominal stoma, up through your ureters, and curl into your kidneys. And those are usually red or yellow in color. They are placed there during surgery, and they will be removed before you leave the hospital or by an ostomy nurse in the community. Sometimes your surgeons do also remove them, and they'll bring you back in to have those stents removed. On the top right hand of your screen, you are going to see what is called a stoma. That is where we take a piece of your intestine and we mature it. So we fold it over and we suture it to your skin. This is what you're going to see on the outside of your abdomen. It does just look like a little red bud. When you go home, your abdomen is just going to have the abdominal appliance on it. So our post-op learning for an ileoconduit are these different steps. First, you're going to learn pouch emptying. There will be instructions on how to empty the ostomy pouches at your bedside. What you're going to see in the beginning is that the nurses are going to empty it into a container. When you're up and mobile, the nurses are going to move you into the bathroom and they're going to teach you how to empty it into the toilet, because that is what you're going to be doing at home. Next, you're going to learn how to change the appliance. This is a great place to have your support person come in and maybe take notes or just be there for support for you as you're learning how to change the ostomy appliances. The nurses are going to be guiding the care on how to change it. They will teach you how to size the stoma, how to cut the flange, how to attach the pouch, and how to open and close the pouch for emptying as well. Next, we're going to go over skin care. There's methods to prevent and treat skin issues that can occur around the stoma. The stoma is used to having urine on it, but the skin is not. So we need to make sure that we are providing care to that skin so it doesn't have any rashes on it. Next, we're going to talk about the urostomy connections. And this is techniques for connecting the urostomy to collection bags. And a collection bag can be a nighttime drainage bag that sits at the side of your bed, or it can be a leg bag that is an extension of your urostomy appliance, so you don't have to empty it in the bathroom as often. Last, we'll talk about ordering your supplies. There'll be information on where and what ostomy supplies to order. This is important because you will be required to purchase these for the remainder of your life. There are specialty pharmacies throughout all of BC and the Yukon that do have these supplies on hand. We'll give you a list of those so that you can contact one of them and purchase from them. There are also pharmacies that have NSWOCs that you can go in and consult with for sizing or any kind of issues that you're having with your ostomy or skincare. Next, we're going to talk about the neobladder. The neobladder uses a really long piece of your small intestine in order to reshape it into a pouch so that it can store urine internally. We actually use about 60 centimeters of your small intestine. For emptying, you empty through your urethra. The neobladder does not have any fullness sensations such as your bladder currently does. So you must learn how to hold the urine and use your pelvic muscles to empty. You actually use your abdominal muscles to empty the bladder. You squeeze it with your abdominal wall muscles, and then your pelvic floor muscles, you learn to open and close those in order to maintain your continence. So continence is something that has to be learned over a gradual amount of time. Leaking urine is common after this surgery, and that's why we ask you to see a physiotherapist that specializes in pelvic floor exercises so that they can help maintain your continence. This is what the neobladder will look like internally. So you have your 2 kidneys, 2 ureters that are reconnected to the neobladder that we have surgically created out of your small intestine, and it is internal. This is what your abdomen will look like in about 6 months after surgery. We use a voiding schedule to help regain your urinary continence, and over a few months, the neobladder will stretch to a size that holds approximately 400 to 600 milliliters of urine, and that is what your current bladder actually holds. So neobladder after surgery will look slightly different than the slide before that I just showed you. You're going to have a few different things that are going to be on your abdomen. You will see several tubes attached to your body, including a urethral catheter, a suprapubic catheter, and sometimes abdominal drains or stents will be inside a bag attached to collect the urine. Those stents through your abdomen and the pouch will be removed before you are discharged from the hospital, but they may be present. So just because you have a pouch on your abdomen does not mean that the surgery did not go as planned. For your hospital discharge, you'll be going home with a urethral catheter and possibly a suprapubic catheter. And that suprapubic catheter is usually just below your belly button. So you have one that goes in your urethra and one that you see on your abdomen itself. Your post-op learning pathway for a neobladder goes something like this. You're going to have your surgery. Then on your hospital stay, you're going to learn how to flush the neobladder through both of those catheters. Next, you will be discharged home, and you will be doing the catheter care with some special instructions that we give you. The catheter irrigation needs to be done at least daily. We will give you those instructions with an instruction sheet on how to do it with some normal saline. You will have NSWOC support. That means that you can connect with them via the telephone, and we will give that information to you prior to your discharge. So if you have any complications, you can always contact them. Last, you are going to have a cystogram, and that usually occurs about 21 days after surgery. That imaging is to confirm that there is no urine leak from all of the surgical sutures that we had to put in to create that neobladder. If there is no leak seen, then the catheter removal can occur. You may experience some leakages several months before you can achieve improved continence. We will talk about flushing in more detail together when we talk about the Indiana pouch. The Indiana pouch, known as a continent cutaneous diversion, is a long piece of intestine, approximately 40 centimeters of your small intestine, and your cecal valve. One end of that is made into an abdominal stoma. How you empty the pouch is by inserting a catheter through the stoma. Typically, this takes only about 4 or 5 minutes throughout the day, but you do have to complete this about 4 to 6 times every single day. The Indiana pouch is designed to be continent because we use your cecal valve from your small intestine. It does not leak urine unless a person forgets to empty it. This is what an Indiana pouch looks like internally. We do have that conduit that will, over a period of time, we will get you to stretch so it can hold up to 400 to 600 milliliters of urine. Then you will have that abdominal stoma that you will see externally on your abdomen, and that is where you catheterize your Indiana pouch through. You do not need to wear a bag over the stoma. Generally, it's covered with a small or light dressing that is easy to change throughout those 4 to 6 times a day that you have to catheterize your stoma. After surgery, about 6 months after your surgery, you will see that you will just have that incision line, midline in your abdomen, and then a small abdominal stoma on your right-hand side, and that will be covered with a light dressing. So your Indiana pouch after surgery, again, will look different than the previous slide that I just showed you. You're going to have several tubes that you're going to notice. First, you'll have a small catheter into the stoma, and again, that is so that we can go past that cecal valve and drain that urine for you. You may also have a suprapubic catheter. Sometimes there's abdominal drains with a bag attached to collect that urine, and those sometimes are called ureteral stents, and they will drain into an ostomy bag, which is temporarily on your abdomen. These will both be removed before you are discharged from the hospital. You will be going home with 2 catheters though until your cystogram. So there is quite likely that you'll have one that goes in through your abdominal stoma, and then you may have a suprapubic one that goes in through your abdomen just below your belly button area. All of those catheters will be removed after your cystogram, and that occurs about 3 weeks after your surgery date. So here is your post-op learning pathway for your Indiana pouch. So again, we're going to start with your surgery. After your surgery, during your hospital stay, you're going to learn how to flush the Indiana pouch through the catheters that are already going to be present after your surgery. You will be discharged home, and with that, you will have the catheter instructions on how to care. You will be required to do your catheter irrigations daily, flushing with normal saline until after your cystogram. Again, you will have that NSWOC support via telephone. So you will have somebody in case you have questions or concerns regarding your Indiana pouch. Then at about 3 weeks or 21 days after your surgery, you are going to have your cystogram, and that is an imaging to confirm that there is no urine leak in that Indiana pouch that we did create for you. If there is no urine leak, then those catheters are going to be removed, and you will learn how to take care of the stoma and flushing the catheters in just a couple slides. A cystogram for neobladder and Indiana pouch. This is a test that is used to check that your neobladder or Indiana pouch is healing well. We want to make sure that there is no urine leaks internally. The cystogram will be done by the radiology department approximately 21 days or 3 weeks after surgery. If you are going home and you don't live in the Lower Mainland, then it may be done at a radiology department that is closer to your home. The process is you will receive a phone call to book your cystogram after discharge from the hospital. On the day of the appointment, please bring your cystogram appointment essentials. This will include photo ID and your care card that is required for the radiology department. An incontinence brief. You will likely be incontinent if the catheters are removed for both the neobladder and the Indiana pouch. Bring a support person. There is lots of information that is given to you during that time. If your support person is available, it's nice for both emotional support as well as absorbing some of the information that will be given to you. And last, bring a bag, because that bag is what you're going to need to carry your supplies in. Sometimes we're able to give you a small amount of supplies, but make sure that you are ready to go to your local pharmacy or a supply store right after the appointment to purchase the supplies that the radiologist does tell you are going to need. So care of the Indiana pouch stoma. So stoma care, once the catheters are removed, is pretty simple. You wash your stoma daily with just plain old water. We don't use abrasive soaps on the skin or on the stoma because it is your intestine. A rule of thumb is if you can eat it or drink it, then it is going to be safe for your stoma. Mucus builds up on the stoma because it is a piece of the intestine. Mucus is often made by the intestine to help move your stool through your rectum or anus. The intestine does not realize that it doesn't have to make mucus, so that is why it is often that it is common for that to build up over time on top of your stoma, or even for you to see shreds of it inside your urine. You need to cover your stoma daily with a small dressing or a stoma cap. The intestine is very vulnerable to air. It is like your mouth. If you leave your mouth open for a really long time, your mouth is going to become dry and almost feels like it's going to be cracked. The mucosa of the intestine is very similar, and so it can become dry over time. So we need to make sure that we're providing that moisture or moisture retention, either using a small dressing or Vaseline and a piece of gauze that you can place over top of that stoma. The stoma may bleed when it's cleansed, and this is completely normal. It is kind of like your gums. If you brush your teeth a little bit too hard, then you're going to bleed a little bit. It is a very vascular organ, so a little bit of blood while you're cleansing it will be expected and is very normal. It may decrease over time as the intestine becomes a little bit more hardy and the stoma becomes a little bit more used to being cleansed with a towel. Leakage may occur from the stoma, indicating that the pouch may be overfilling and requiring more frequent catheterizations or irrigations to thin out that mucus buildup. A medical alert bracelet or necklace should be worn with an Indiana pouch. On that medical alert bracelet, you want it to say Indiana Continent Urinary Diversion. The stoma must be catheterized every 4 to 6 hours with a specific French size catheter. You will not know what size catheter you need until after your cystogram. Once those catheters are removed, they will tell you what size French catheter you will need. The medical alert bracelet is something that you can purchase about 6 weeks after your surgery. The reason it's really important is that if you have a medical emergency where you are unconscious, that EMR or the medical response person needs to know that you have an abdominal stoma that has to be catheterized to make sure that you don't start having overflow of urine and back up into your kidneys. So that medical alert person needs to be aware of the catheterization needs so they can communicate in your medical emergency as well. Irrigation for the neobladder and the Indiana pouch. Before you leave the hospital, you must know how to flush those catheters. This will occur twice a day, every single day. Here is an example of the information sheet that you can be presented with from the hospital. This one is from Vancouver Coastal Health, but your health authority should have something very similar to this if they do not use the Vancouver Coastal one. For the neobladder, you will have an indwelling and a suprapubic catheter until your cystogram. For the Indiana pouch, the catheter through your abdominal stoma and your suprapubic catheter, both of these need to be irrigated. So for the neobladder, you have 2 catheters that need to be irrigated, and for the Indiana pouch, you also have 2 catheters that need to be irrigated. Bypassing around the catheter is related to the mucus plug and mucus buildup. Sometimes you need to add some extra normal saline to irrigate through both of those catheters to flush and thin out that mucus. Sometimes you will only have one catheter that is draining, and that is okay. As long as one of those catheters is draining all the time, then we are emptying that bladder. Here's an example of a catheter irrigation. It is a video that you can watch to learn how to do it with confidence. You will need to irrigate all of those Foley catheters twice a day, every day until your cystogram. So please use this video. There's a link below at the bottom of your screen to watch and learn over and over. Your voiding and catheterization schedule. After the cystogram and the catheters are removed, there's going to be a very important voiding and catheterization schedule that you must follow. Neobladders and Indiana pouches will increase in size and capacity over time. It is very rigorous for the first few weeks. As you can see, week 1 and 2, while you're awake, you're going to be emptying those catheters every 1 to 2 hours. While you're sleeping, you're going to set an alarm if you have to, and you're going to get up every 2 to 3 hours in order to void and catheterize those pouches. When we turn into weeks 3 and 4, we start to extend that length of time. While you're awake, it'll be every 2 to 3 hours, and while you are night sleeping, it will be every 3 to 4 hours. Then in weeks 5 and 6 and 7 and 8, those do expand again. So they go from 3 to 6 hours while you're awake, and then at nighttime from 4 to 8 hours, depending on which week you're in. Over a few months, the pouch will gain capacity, and it will stretch to hold approximately 400 to 600 milliliters of urine, which is the normal capacity of a bladder. So right now we're going to talk about preventing hernia and safe activity after surgery. During the first 6 to 8 weeks, you're going to gradually increase your activity. That may include some light walking or maybe some light weights. Nothing more than that. You're going to avoid all heavy lifting for approximately 3 months post-surgery. Heavy lifting does include anything above 10 pounds. So you want to make sure that you are not doing things like vacuuming or lifting up the laundry, because all of that is included in more aggressive activity. One of the other things that is important to do is to support your abdomen and your abdominal muscles as they are healing. That is called splinting. You can use your arm or a pillow across your abdomen and across your abdominal stoma before you are coughing, sneezing, or straining. That's important because you will increase your abdominal capacity when you do any of those things and strain those muscles. By putting your arms around them and splinting using a pillow, you are going to hold in those muscles during those activities. Strengthening abdominal muscles can help prevent hernias. You should ask your physiotherapist and or your surgeon if you are allowed to start increasing your daily activities. If it is something that you do on a regular basis, let's say you are a heavy-duty mechanic or you do lots of physical activities, you teach physiotherapy or you teach soccer, this is something you want to talk to with your physiotherapist prior to going back to these activities. There are hernia supports as well as hernia prevention belts that you can get prior to going back into these activities. A physiotherapist may be consulted and can be very helpful to increase your core strength through guided exercises and recovery support. That physiotherapist can also give you information on pelvic floor physiotherapy exercises. With a neobladder and an Indiana pouch, it is really important that these exercises are done in order to achieve and maintain continence throughout the rest of the lifetime of you and your neobladder and your Indiana pouch. You should consult with a physiotherapist before surgery as well as post-surgery. You can also attend the pelvic floor physiotherapy module on the BCSC program, which will be an e-learning module, and you can access that through the website. Here's an example of a couple of these exercises. This one here is for your Kegels. You're going to pull the muscles from your anus, and it feels like you're pulling them up into your belly button. You're going to pull them in and you're going to hold them for 3 seconds, and then you're going to release them. And you're going to do that 10 times in a row, 3 times a day. Those are called your Kegel exercises. It is what squeezes those pelvic floor muscles around that urethra and stops the urine from flowing. And that's part of how you gain control after you've had a neobladder. The next one is learning how to do your abdominal wall exercises. These are very important when you have a neobladder because you actually have to squeeze that neobladder with your abdominal wall muscles so that when you squeeze them, it empties out that neobladder. Remember, the neobladder has no sensation of fullness, so you have to remember to empty that neobladder approximately every 4 to 6 hours. Otherwise, you will have problems maintaining your continence. You will need those Kegel exercises in order to maintain that continence as that neobladder slowly fills up. You're going to need those Kegels to support the closure of your urethra and maintain your continence. Traveling with an ileoconduit or a continent diversion is definitely something that you should be doing. You should not decrease your quality of life by having a continent diversion. So here's some traveling tips. Always pack 3 times the number of supplies with you. Some countries may not have the same supplies as you. There are different quality of supplies that you can get in Canada and the United States compared to other countries across Europe or let's say Africa. They may not have the same supplies, so you want to make sure you're taking enough with you in order to get through your vacation as well as get through any complications that may arise. Be aware of the temperature differences that may affect your ostomy appliance wear time. Let's say you're in Thailand and it is very muggy. That ostomy appliance, which uses glue on your skin to stick, may not stick as well now that you're sweating a lot and now that there is a lot of moisture in the air. You may have to change that ostomy appliance more often. So if you're changing it 2 times a week in Canada, you may actually have to change it 3 or 4 times a week while you're in Thailand. So that's why you take all of those extra supplies with you. Take those supplies in an extra carry-on luggage, except the liquids. A lot of the airlines now will provide you with a medical bag or medical carry-on for your supplies if you request it ahead of time. So contact your local airline that you are using and see if they will give you that extra carry-on bag for your medical supplies. Don't forget your medical alert bracelet or necklace. This is again very important that when you are out of country or even across country and you have a medical emergency, that they do know that you have an Indiana pouch or even a neo bladder through your medical alert bracelet. Here is an example of a card that you can get from the Ostomy Canada Association. It is a card that is meant to give information to the security that is at the airport. On it can say that you may need to have a bathroom more frequently, and also that you should be able to have a private screening area. Sometimes if you have a little bit of urine in your pouch, it may look like you have a bulge underneath your shirt. You are allowed to have a private screening area. If that security officer asks you to lift your shirt, you can say no, and you can hand them this card that gives them the information that you have a urostomy or an ileoconduit discreetly. You don't have to tell everyone that is surrounding you about your ileoconduit. There are support groups that you can get yourself involved in. So we do have the bladdercancercanada.org support, and that is peer-to-peer support. We also have the BC support at bladdercancercanada.org. The United Ostomy Association is part of our Vancouver chapter, and here's the email, vuochapter@gmail.com. We have a young people's ostomy group as well, and that is for people ages 20 to 50, and you can get to that group using this email, and it's unitedostomy2017@gmail.com. And then lastly, we have our BC urinary continent diversion support group for neobladders or Indiana pouches. And here is the Gmail that you can connect for those meetings as well. Common questions and answers for some of these questions that I often hear pre or post sessions, education sessions. So first, self-care. Can I shower or can I go swimming with an ostomy pouch? And the answer is absolutely yes. These ostomy appliances are designed to be water resistant. You can wear them in a hot tub, you can wear them in a swimming pool. All you have to do is make sure that you dry them off afterwards. And you can do that using a hairdryer so it doesn't sit wet on your skin. They do not leak just because they come into contact with water. Now, make sure that you do know that you can shower with the ostomy appliance on. Remember, your abdominal stoma is intestine and it is used to water. You do not have to worry about keeping water off of your abdominal stoma. Next, why was I given all 3 options for surgery? And all 3 options for surgery means the ileoconduit, the neobladder, and the Indiana pouch. Everybody's health journey is individualized. Sometimes all three options may not be available to you. And there are some reasons why. For a neo bladder, you have to have very good control of your abdominal wall muscles as well as your pelvic floor muscles. If you've had several surgeries prior to abdominal surgeries that may interfere in that strength or that ability for you to be able to control the flow of urine by squeezing those muscles, then the neobladder may not be an option for you. Also, if you have any kind of memory problems or memory issues, it will also not be an option for you because you do have to remember to squeeze that neobladder empty. You do not have the nerve endings in that neobladder to tell you that it is full, unlike your bladder currently. Also, for an Indiana pouch, you have to have very good dexterity in your fingers. If you have things such as arthritis or any kind of numbness in your fingers or lack the dexterity to be able to catheterize that abdominal stoma 4 to 6 times a day, then that also will not be an option for you. So there is different reasons why your surgeon did not give you all three options for diversion surgeries. If you have any questions or concerns, please bring that back to your surgeon and they will tell you why those other options were not given to you. Question number 3. If part of my bowel is taken, does it change the way I pass stool? Will I have diarrhea over time? So for the first 2 surgeries, your ileoconduit and your neobladder, you may experience some diarrhea in your fresh post-op periods. And that's because the intestine has just been altered. It will take a little bit of time for it to get back into a pattern of moving your bowels normally. For the Indiana pouch, we do have to take the cecal valve. That means that you may have looser stools more often throughout your lifetime post-Indiana pouch. It does not mean that you will have diarrhea or that you will have stool incontinence. It just means that you may experience more frequent and more urgency with your bowel movements if you have an Indiana pouch. There are other online resources that you can also look up. This is a website called the Vegan Ostomy, and this person does have a great blog that answers a ton of questions. So what should I know for each option? So I'm going to go through the different pros and cons for each one of the surgical options that we just discussed. The first one we're going to talk about is the ileoconduit or the urostomy. The advantages are it's a very common and very well-known surgery. There's a strong community support because it is such a common surgery. The bag can be attached to a larger reservoir, so the pouch that is on your abdomen can be attached to a leg bag, so you do have more time in between you having to empty. You empty directly into the toilet, and if over time you need assistance, a family or a caregiver can be taught how to change the appliance and also how to empty it. Important considerations are you have to wear a pouch 24 hours a day, 7 days a week. Skincare around the stoma becomes very important because you do have to change that appliance 1 to 2 times a week and provide skincare. If you don't, then you will have breakdown of that skin from the urine and you will have some rashes that you'll have to deal with. Body image is another thing that does come into a consideration. Some people really do not like having an external pouch that they have to see, and that can be seen sometimes underneath their clothing. Special care requirements for an ileoconduit are pretty low. You just have to empty the pouch and change the appliance when leaking or every 3 to 5 days, twice a week. So it's pretty low for self-care requirements. Ostomy appliances have to be purchased. There's also ostomy accessories that you can purchase as well. And these come from pharmacies all throughout BC and the Yukon. You do also have the capability of having a daytime and a nighttime collection bags, which will extend your length of time that you have to empty. For a nighttime, you'll probably be able to sleep throughout the entire night without having to get up to empty that urostomy bag. Expenses, unfortunately, are high for these because you do have to purchase each one of these ostomy appliances that you have to change once to twice a week. Each ostomy appliance is about $12 to $15. However, there are lots of options for coverage, and we will be discussing this in another presentation. We do have BC Fair Pharmacare coverage, disability tax credit, and other tax benefits that we will discuss for lots of coverage for these ostomy appliances. Our next surgery that we're going to discuss is the neobladder. So the advantages are that you empty the neobladder using your urethra to void, which means that you still sit on the toilet and you squeeze those muscles. There is no external bag, so some of those body image concerns that you have with an ileoconduit do not happen as frequently as with a neobladder. Important considerations are it requires very good muscle strength and muscle control to empty and to prevent leaking of urine. It requires a number of months to complete the voiding and catheterization training to stretch that neobladder so that you can get to that optimal level. It may require catheterizations for the rest of your life to fully empty that neobladder if you cannot fully empty it by squeezing your abdominal muscles. And you need to remember to void. So you have to have that knowledge and capability to know that you have to go to the bathroom every 4 to 6 hours to empty your neobladder. That also means that you have to remember that throughout the nighttime. And sometimes you have to set that alarm in order to get yourself up to empty that neobladder. You do not have the fullness sensations that you have to void. You will not know that your neobladder is full. And if you do not get up to empty it, leakage will occur. So the self-care requirements are moderate to high. You need to do those pelvic floor exercises in order to make sure that those pelvic floor muscles are strong enough to close off that urethra and prevent the leakage from occurring. You have to remember to void. So you do need to have that memory capability to be able to go to the bathroom every 4 to 6 hours. And remember, right now that may not be a concern of yours, but let's think about 10 to 15 years down the road. We have to make sure that we do have that memory capability. And if you don't, then you will end up with a catheter. And sometimes we do need to catheterize that neobladder in order to fully empty it. So finger dexterity is required for catheterizations. The supplies are very minimal for a neobladder. Sometimes you need the intermittent Foley catheters, and sometimes you need the incontinence pads of briefs, especially in that first 3 to 6 months where you are learning how to control your abdominal wall muscles and increase the strength of your pelvic floor muscles so you close off that urethra. Incontinence is common with neobladder in that first 3 to 6 months, so just be prepared for that. The expenses are low to moderate. It depends on the degree of urinary leakage and or the need to use catheters to fully empty the bladder. If you cannot squeeze that bladder completely empty, then the cost of the catheters will be there. And the intermittent catheters can range from anywhere from $1 to $3 for each catheter. And if you have to do that 4 to 6 times a day, that cost will add up. For your Indiana pouch, your advantages are you empty by inserting a catheter through that abdominal stoma. The stoma does not need a bag to cover it. You just need a discreet small dressing in order to cover the stoma. You usually will have improved body image and minimal to no leakage of urine. as long as you remember to catheterize that stoma often enough. Important considerations requires very frequent catheterization, initially to stretch out that pouch. Remember when we talked about the voiding and catheterization schedule, in the first 1 to 2 weeks, you're looking at every 1 to 2 hours. So it is very rigorous and you have to stick to it. It requires catheterization every 4 to 6 hours for life to void. So leakage will occur if you forget to empty the Indiana pouch. So if you forget to catheterize that stoma, it will actually leak urine through that stoma. The self-care requirements are high with an Indiana pouch. You do need to have finger dexterity required for that catheterization. You have to remember to empty that catheter, and you must wear a medical alert or an equivalent all the time, so that in a case of a medical emergency, your caretakers will know that they have to empty that for you. The supplies for an Indiana pouch are intermittent Foley catheters. So again, they cost about $1 to $3 each. There are more expensive ones as well. It really comes down to what is needed for your Indiana pouch. And you also need a small dressing or gauze to cover the stoma. You can minimize expenses here by using something as simple as a little bit of Vaseline on top of the stoma in order to keep it moist, and then just a sterile plain gauze with a little bit of paper tape to cover it. Remember, you have to change this dressing 4 to 6 times a day, because every time you go to catheterize, you will be removing that dressing and putting a new one back on. There are also silicone dressings that you can purchase, and usually they're about $3 to $5, and those can be reapplied throughout the day, so they're good for 24 hours, but that's another way of minimizing or transitioning your costs. So expenses are high for an Indiana pouch. There is no BC Fair Pharmacare coverage for any of those intermittent catheters. We are advocating and trying to get this changed for the future, but as it stands right now, you do not have coverage through BC Fair Pharmacare. You also do not get the disability tax credit the way that a person that has an ileoconduit or an abdominal stoma with a pouch, they can get the disability tax benefit. And unfortunately, you don't get that with an Indiana pouch. Thank you everyone for joining our session today. If you would like to participate in any of the modules, please contact our program assistant, Saran Tesfaye.